Hello everyone. So now we are going to discuss on the third part of the unit from this biochemistry. So it's the catabolism of purine nucleotides, hyperuricemia, it's a pathological condition, and the gout. So before starting the presentation, I would like to say that this purine nucleotide, actually these are the basic building blocks of the genetic materials, right? That is the DNA and the RNA. And as we know that how the biosynthesis of this nucleotide takes place, similarly they have different pathways which are associated with their catabolism, right? Now if something or some mismanagement it occurs in their catabolism, then pathological condition like hyperuricemia and gout it develops in an individual. So in this presentation we are basically going to describe about the catabolism of the purine nucleotides as well as the hyperuricemia and the gout. So let's start the presentation. So basically you see in the background, if we see the catabolism, first of all these purine nucleotides, these are actually sequentially degraded by the removal of the portion of the nucleotide. Means this purine nucleotide, these are first degraded by removing that nucleotide, removing that portion of the nucleotide, right, in a sequence manner, or you can say in a sequential way. Moreover, the end product of the purine metabolism or catabolism, you can say it is always the uric acid which is formed. And the mammals other than the primates, they oxidize this uric acid into allantoin. That is a further step, right? And now let's discuss the nucleotides of cell undergo continual turnover. How this turnover actually occurs. So basically some of the bases these are reused. After the degradation, some of the bases which have formed, they are reused, and regarding this thing we have already discussed in the salvage pathway, right? Now the others, they are degraded to product that are excreted from the body. Now uric acid, again I am repeating, it is the end product of this catabolism. So animals other than the mammals may further degrade this end product into urea or ammonia, and the uric acid, it is generally excreted from the body via the urine. So let's discuss what are the steps. So sequentially if you see, the first step, it is nothing but an amino group, it is removed from the AMP to produce a IMP. IMP is the inosine monophosphate, right? Or adenosine to produce inosine. It is the first step of the step. The next step, it is that the IMP and the GMP are now converted into their nucleoside. Now the second step, it is the IMP and GMP, they are converted into their nucleoside forms which are known as ionosine or guanosine. The third step, it is the ionosine or the guanosine, and now they are going to get converted into the respective purine bases, just like hypoxanthine and guanine by the purine nucleoside phosphorylase. I am going to give you the details in the next slide. Now the adenosine, it is not degraded by the enzyme, by this enzyme, so it has to be converted into the ionosine. I repeat, adenosine cannot be degraded by this enzyme, that's why it needs to be converted into ionosine. The next step, the guanine undergoes deamination by the enzyme guanase to form the xanthine. Then now this xanthine oxidase, it will convert this xanthine into hypoxanthine, and this xanthine again it gets converted into uric acid. Now what is the enzyme? That is this, or what is their cofactor? That this enzyme, it contains the FAD, molybdenum and the iron along with it. Moreover, it is exclusively found in the liver as well as in the small intestine. So this xanthine oxidase, it liberates the hydrogen peroxide, and we all know that the peroxide, it is harmful to our body. Does this peroxide, it get converted into water and a molecule of oxygen. Now this is the conversion. You see here, this AMP deaminase, it will act on the AMP to convert it into IMP, inosine monophosphate formed here. it will get converted into inosine. Again, this inosine will get converted into hypoxanthine to xanthine, and this xanthine is finally going to get converted into uric acid. If we start with here, the AMP sometimes it get converted into adenosine. This adenosine get converted into inosine. Again, it will follow the same pathway. Similarly, GMP it get converted into guanosine. This guanosine is converted into guanine, and after forming the xanthine, it will follow the same step. These are the enzymes which are responsible for its conversion. Now let's start the next part. So here I am showing you, see, this is the AMP. Now by virtue of the enzyme nucleotides, it is going to get converted into adenosine. From here it is again going to convert into inosine. Now inosine can be also formed from the IMP with the help of the enzyme nucleotides, and finally it is going to get converted into hypoxanthine. So inosine get converted into hypoxanthine by the virtue of the enzyme PNP, that is your purine nucleoside phosphorylase. But you have to remember one thing, that I have written here, adenosine it is not degraded by the PNP but it converted into inosine and further metabolized in the body. Now once this hypoxanthine is formed, this hypoxanthine by virtue of the enzyme xanthine oxidase it get converted into xanthine, and this xanthine again by virtue of the enzyme xanthine oxidase it get converted into uric acid. Similarly, the GMP it get converted into guanosine, then to guanine, and again it will come or it get converted into xanthine. This is the basic reaction. You can see this means particular flow chart. Here I have shown you in the diagrammatic way. Now again if you see the AMP it get converted into adenosine to inosine. Similarly the IMP it get converted into inosine, the same step only. And here similarly you get the XMP it get converted into xanthosine, which further get converted into xanthine, and similarly this way. Now xanthine oxidase, this is an important enzyme actually in the catabolism of the nucleotides. So where it is found? So basically it is found in the liver and the small intestine. Moreover, it is a metalloflavoprotein. This enzyme, it contains the FAD, molybdenum and the iron. Moreover, the reaction produces the hydrogen peroxide, and this hydrogen peroxide by virtue of the enzyme catalase it gets converted into water and the molecular oxygen. The next step here, you see here the breakdown of the endogenous purine. So it led to the formation of the purine nucleotide in the body. Moreover, the purine also come from the diet, also from the de novo synthesis, which we have already discussed. So now the body uric acid pool in the man it is around 1200 mg, and in the female it is around 600 mg. So this uric acid now it get distributed. 2/3 of the uric acid it comes to the kidney for the process of excretion, whereas the remaining amount it goes to the gut, and it is degraded into carbon dioxide and ammonia, right? So the normal serum uric acid concentration. What is the normal serum uric acid concentration? First of all, you should know that 3 to 7 mg per deciliter in males it is found, and 2 to 5 mg per deciliter in the females. It is the normal concentration. Moreover, the uric acid pool for the man it is 1200 mg. Excretion per day it is 500 to 700 mg, and uric acid it is cleared by both the glomerular filtration as well as the tubular secretion in the kidney. Moreover, you should know that the uric acid it acts as a natural antioxidant in the human body. Now uric acid metabolism. So how this metabolism takes place? So let's start point after point. So uric acid it is the final breakdown product of the purine degradation in the human. We know that, right? Now as it is a weak acid, it have a dissociation constant of 5.75 and a 10.3 in the acid and basic medium, right? The urates, these are the ionized form of the uric acid, right? It predominates in the plasma, extracellular fluid, synovial fluid, with 98% existing as a monosodium urate at 7.4 pH, that is the blood pH. So the question may be asked like that, in what form it is the uric acid it is present in the blood, because the pH of the blood it is 7.4. So generally the urate it remains as a monosodium urate at the pH of 7.4. The next thing you should know that the plasma, it is always saturated with the monosodium urate at a concentration of saturation concentration of uric acid in the, or you can say monosodium urate in the plasma, it is 405 mole per liter. That is equivalent to 6.8 mg per deciliter at 37 degree. But now, if the concentration it rises above the 405, then what will happen? The plasma is therefore now supersaturated, creating a potential for formation of urate crystal precipitation. I repeat this thing, means once the concentration of the uric acid it is approximately around 6.8 mg per deciliter, till then it will remain in the solubilized form. But once the concentration it exceeds this threshold amount, the uric acid crystal starts forming in the body. Right? Now the plasma urate concentration can reach up to level of 4,800 mole per liter, or you can say 80 mg per deciliter without precipitation. Sometimes in some patients, means it can cross this 6.8 mg per deciliter threshold. It can sometimes reach the 80 mg per deciliter concentration, the monosodium urate, but it cannot get precipitated in some condition. It is due to the presence of the, actually it is the presence of the solubilizing agent or solubilizing substance in the plasma. The next thing you should know that the urine, the pH of the urine, it greatly influences the solubility of the uric acid, right? Now at the pH of 5, in the pH of 5, the urine it is saturated with the uric acid at a concentration ranging from 360 to 900 mole per liter, that is equivalent to 6 to 15 mg per deciliter, right? Now at the pH of 7, when the urine pH it reaches the means the normal condition, or you can say the neutral pH, the saturation is reached at a concentration of 9480 and 1200 mole per liter, that is equivalent to 158 and 200 mg per deciliter, right? Moreover, the ionized form of the uric acid in the urine, the ionized form of the uric acid in the urine, that is an important thing. What are the ionized form? It is generally the mono and disodium, potassium, ammonium and calcium urates. So in this form you can find the uric acid in the body. These are the mono, disodium or potassium or ammonium or calcium urates, means they are forming the salts, right? Now the purine nucleosides, these are synthesized and degraded in all the tissue of the human. So the thing is that the urate, it is produced only in the tissue that contains the xanthine oxidase. So it is very important that only those tissue like liver and small intestine can produce the uric acid, because the xanthine oxidase it is primarily present in the liver and the small intestine in the human body. Moreover, the urate production it varies with the purine content in the diet actually, and the rates of the purine biosynthesis, degradation and salvage. So the urate production it totally depends upon the purine content in the diet. Whatever the amount of the purine you are taking in your diet, more about the purine biosynthesis, what is the rate of the purine biosynthesis in your body, the rate of the purine degradation in your body, more about the salvage pathway, right? So normally 2/3 to 3/4 of the urate is excreted by the kidney, which I have already shown in the figure, and most of the remainder it is eliminated through the intestine in the form of carbon dioxide and ammonia, right? Now the kidney clear urate from the plasma, right? The kidney is the filtering organ, so it is going to clear the urate from the plasma and maintain the physiological balance by utilizing the specific organic anion transporter, which is known as OAT, organic anion transporter, including the urate transporter 1 and human uric acid transporter HUAT. So this kidney will utilize these two transporter actually, right? Now you see the urate 1 and OAT, that is your organic anion transporter, they carry the urate into the tubular cells of the kidney from the apical side of the lumen in the kidney. I repeat, the urate 1, the carrier, the urate 1 and the OAT, they carry the urate into the tubular cells from the apical side of the lumen, right? Now once inside the cell, what will happen? Once inside the cell, the urate must pass through the basolateral side of the lumen in a process which is controlled by a voltage dependent carrier. Now, which is a voltage dependent carrier in the body, that is in the kidney, that is a human uric acid transporter. It is a voltage dependent carrier in the human body. So basically, the uric acid excretion, it is composed of 4 component models. So what are the models? The renal handling of the urine, or you can say uric acid, it is controlled by the 4 component model. These are the models. First of all, you are having the glomerular filtration, next the tubular reabsorption, next is the tubular secretion, and then the post-secretory reabsorption. So that this process have been considered sequential, and it is actually now apparent that they are carried out in parallel. So these all process, they are going to happen in a parallel way, simultaneously, right? Now let's discuss the pathological condition which is known as the hyperuricemia. So what is hyperuricemia? The name itself it suggests that hyper means more, uricemia means a high amount of the uric acid, right? So hyperuricemia, it is an excess of uric acid in the blood actually, right? So this uric acid actually passes through the liver and enters the bloodstream. Now the thing is that most of the uric acid, it gets excreted from via the urine or passes through the intestine to regulate the normal levels in the human body. But you should know that an important, also if these are important to the blood uric acid levels, and so you should know one thing, that these uric acid, they are also important to the blood uric acid levels are purines. So purines, they are also considering, or you can say they are also controlling the level of the uric acid in the body. Now this, we know that the purine, these are the nitrogen containing compounds, so which are made inside the cell of our body endogenously, and sometimes they come outside from our body from the food we used to take. Thus the purine breakdown, it leads to the production of the uric acid in the human body, right? So increased level of the uric acid from the excess of the purine may accumulate in the tissue and form crystals. So this may cause high uric acid levels in the blood. So that is the condition. So the thing is that you see the normal uric acid levels, it varies between the genders, 2.4 to 6 for generally the women, and 3.4 to 7 for the men actually, right? So there always exists a variation between the gender. So you can say it's a gender variation secretion. Moreover, the upper limit lies at 7 mg per deciliter of the uric acid, whereas where any higher puts us at a risk of developing hyperuricemia. The cause of the hyperuricemia, it is actually basically divided into 3 categories in the body. Means if somebody asks you how hyperuricemia takes place, it may be due to the uric acid under-excretion. Means when the uric acid has formed, the amount of the uric acid, it has gone out, or the excretion mechanism, it is not working properly. Thus you can say uric acid under-excretion, it is a contributing factor for the pathological condition of hyperuricemia. Next it is the uric acid overproduction. If the production of the uric acid is high in the body, then also the patient may suffer from hyperuricemia, and sometimes combined, means both the reasons, they are combined togetherly, it leads to the formation of hyperuricemia. So now under-excretion, in which condition the amount of the uric acid, it remains under-excreted. So see, under-excretion, it actually make up most of the cases of the hyperuricemia, because the body, if it is not able to clean out or slug off or flush off the uric acid from the body, then the person suffer from hyperuricemia. So urate, we know that it is a salt of the uric acid, it is filtered by the kidney, right? It undergoes a process that ends as in the urate leaving the body through the urine, right? Now one misstep in this process of the excretion can result in the renal insufficiency, thus lead to the poor rate of uric acid excretion from the body, right? So under-excretion, or you can say poor kidney function, can be caused by the following reasons. So in which condition under-excretion of uric acid it takes place? First of all, you see renal insufficiency, means the kidney is not working properly. That in this case of the renal failure, or you can say uric acid remains in the blood, as the kidney they are unable to clear off the uric acid, and that will lead to the high amount of the uric acid in the blood. First condition, it is the renal insufficiency. The second condition, it is nothing but the metabolic syndrome. So other health complications such as hypertension, obesity, or you can say insulin resistance, they also contribute to the decreased excretion of the urate by the kidney. In these conditions like hypertension, obesity, or insulin resistance, the amount of the excretion of the uric acid from the body, it comes down, as the kidney it is not able to slug off or flush off. Next, medication, diuretics. If you are taking diuretics or low dose of salicylates or cyclosporine or nicotinic acid, they have been linked to the poor excretion performance by the kidney. So drugs like diuretics drug, or you can say low dose salicylate like aspirin, cyclosporine, or nicotinic acid, they actually degrade the performance of the kidney, right? Moreover, other conditions which include the genetics. So while considering the rare, but the patient with this condition experience progressive renal failure. So sometimes if the kidney failure it is a reason for the inheritance or genetics, in such cases the patient may suffer from hyperuricemia, right? Hypertension we have already discussed, that high blood pressure and the associated medication, they have been known to cause the hyperuricemia. So sometimes it is preferred not to take the antihypertensive drug at the early stage of the life, because we know that the person they became dependent on the antihypertensive drug. So once you are taking the antihypertensive drug for a long while, then this may have impact on the filtration property, or you can say on the performance of the kidney. The next condition, it is the acidosis. So we know that the condition that increases the acidity in the blood, such as alcoholic ketoacidosis. Alcoholic ketoacidosis, it increases the acidity. Moreover, diabetic ketoacidosis or lactic acidosis or starvation acidosis, they can cause the poor kidney function and hyperuricemia, right? The next condition, it is the preeclampsia or eclampsia. These are often associated with the elevated uric acid level, which can cause the hyperuricemia. And generally, these two conditions, preeclampsia and eclampsia, it is found in the pregnant woman. The next condition, it is the lead exposure. It is a chronic condition actually. So clinically studies, they have shown that the occupational sometimes, or you can say prolonged exposure to lead, if the person he is exposed to lead for a long time or sometimes for a short time also, this can also affect the function of the kidney. Another condition includes the hyperthyroidism, the hyperparathyroidism, sarcoidosis, and trisomy 21. These are the other conditions which are associated with the poor efficiency of the kidney to excrete the uric acid, or you can say urate crystal. The next condition which is responsible for the hyperuricemia, it is the overproduction. So this overproduction occurs in a minority of the patient actually who have hyperuricemia. So hyperuricemia induced by the overproduction may be caused by external factors. What are the external factors? If you are taking high amount of the purine containing diet, then the chances of production of uric acid in the body it increases. Moreover, there are some internal factors also, like increased purine breakdown in the body. So thus you can say the overproduction of the uric acid can be caused by the following conditions. What are the conditions? So first of all, diet. So if the diet contains high amount of the purine, like if you are taking high meats, right, or organ foods, or you can say legumes, high protein content diet, they contribute to overproduction of the uric acid in the body, right? The next condition, it is also known as the Lesch-Nyhan syndrome. What is Lesch-Nyhan syndrome? This type of things you should learn for the multiple type of question which generally is to comes during the exam time. So Lesch-Nyhan syndrome, this is the process actually. If we define it, the process involved in this syndrome contribute to the overproduction of the uric acid. In this particular syndrome, the person produce over amount of the uric acid. In patient with these symptoms, they are also more likely to develop gout. This Lesch-Nyhan syndrome, right? Next, it is the Kehle-Segmiller syndrome. Here, what actually happens? The patient in this syndrome, actually in this type of patient, the process here actually the process involved in this syndrome contributes to the overproduction of the uric acid, and patient with these symptoms, they are more likely to develop gout. These two are the condition, pathological condition. First one, it is the Lesch-Nyhan syndrome. Next one, it is the Kehle-Segmiller syndrome. Here the chances of development of the hyperuricemia as well as the gout, it increases. The next one, it is the increased nucleic acid turnover. So the process involved in this syndrome contribute to the overproduction of the uric acid. Moreover, the patient with this syndrome, actually they are more likely to develop the gout and also the kidney stones. The next condition, it is the tumor lysis syndrome. Here actually this syndrome, it is also known to produce the most serious complication of the hyperuricemia, the tumor lysis syndrome. The other conditions include the glycogenosis 3, 5, 7, moreover exposure to organic pollutants. All these conditions, they would lead to the overproduction of the uric acid in the body. Now, the third type, you can say the third promoting condition, it is the combination cause of these two. So, a combination of overproduction and under-excretion can provide a efficient condition for development of the hyperuricemia, right? Now, the combination of both the mechanism can put the patient at a higher risk for development of the complication. The combination can be resolved with the following. So, what are the conditions? Number one, alcohol consumption. So, alcohol consumption actually increases the production of the uric acid, and also it produces the competing compounds that lead to the decrease in the uric acid excretion by the kidneys. First of all, it's the alcohol consumption. The next one, it is the fructose foods and drinks. Thus, you can say the fructose actually it increases the uric acid levels by increasing the purine metabolism in the body. You should know that the fructose, it stimulates the overproduction of the uric acid by increasing the purine metabolism. Moreover, it has been now found that the fructose, they play a hands in decreasing the kidney function and uric acid excretion in the human body. Moreover, rapid weight loss. So if a person he is on a rapid weight loss, suppose controlling his diet also, this rapid weight loss is enhance the breakdown of the tissue from the unhealthy, or rapid weight loss may produce more uric acid and decrease the excretion due to the sudden or rapid change in the uric level in the body. The next condition, it is the deficiency of the enzyme aldolase B. So this is a common genetic disorder found in the patient, right? Now, patient with such deficiency of aldolase B enzyme, they are likely to develop gout. Next one, it is the glucose 6-phosphate deficiency. If the patient is deficient of glucose 6-phosphate, he can also develop kidney complications or sometimes kidney failure. Now, the next part in this discussion, it is the gout. So, how it actually forms. So, here I am showing you in the structure, RNA and DNA, they get converted into purine. By virtue of the PRP, it get converted into hypoxanthine. From the hypoxanthine, it get converted into xanthine, and from this xanthine, it get converted into uric acid, right? Now, high amount of the uric acid may cause the hyperuricemia, gout, or deposit of the uric acid crystals in the joints, and sometimes it can also lead to the nephrolithiasis, right? So, gout. What is gout? Gout is a metabolic disorder of purine metabolism, and it is characterized by intermittent attack of the acute pain and swelling and even inflammation. It takes place in the person, right? Now, it always preceded by hyperuricemia. So once the person is suffering from hyperuricemia, the next consequences will be the development of gout, right? Now, this hyperuricemia, due to the excess amount of the uric acid production or decrease in the amount of the uric acid from the body, that is leading to the condition of the hyperuricemia, right? So hyperuricemia, generally it is considered as a primary or secondary, and the primary hyperuricemia, it is again classified as overproducer and under excretors. So regarding this, we have already discussed, right? Now acute gout. So first of all, you see, in acute gout you are going to have painful arthritic attack of sudden onset. The patient may suffer from painful arthritic attack suddenly. Moreover, it usually occurs during the night and in the early morning. So in the early morning the patient may suffer from pain. So arthritic pain, it worsens progressively with the lifetime. So if you develop this gouty condition in you, then the condition of the gout, it progresses with the age. Moreover, this acute gout is generally involves one or few joints in the human body, and it most common site of initial attack, it is generally nothing but it is the metatarsophalangeal joint, right? And other side, it includes the ankle, heel, knee, wrist, elbow and fingers. Here the patient may suffer from pain. The chronic gout, what are the conditions of the chronic gout? Frequency of attacks now will increase. Earlier it was during the night time or early bedtime, now it will increase. And along with that, continuous deposit leads to the damage of the joint, or you can say chronic pain will start. Now, the patient in such cases, they develop large subcutaneous tophi, or you can say stones. They develop stones in the pinna of the external ear, eyelids, nose and around the joints. Now the uric crystal in the kidney leads to the renal disease in chronic gout, and actually the articular cartilage may be destroyed as a result of joint deformities. Now what are the risk factors for the gout? First of all, you see, I have shown you male sex. Means male sex, here I am representing for male the chances of developing the gout, it is high. Moreover, with the increasing age, the chances it develops. Moreover, socio-economic deprivation. The next one, it is the Polynesian ethnicity. Means it depends upon the ethnic makeup or genetic makeup of the person, right? Obesity, it is a contributing factor. Moreover, chronic renal impairment or renal transplantation, cardiovascular disease and type 2 diabetes, hypertension and heart failure, hypertriglyceridemia and psoriasis, diuretic and cyclosporine drug uses. So these all are the risk factors for the gout. Now what are the factors that triggers the gout? The factors triggering the gout are, first of all, heavy alcohol intake. We have already discussed regarding the alcoholic intake in the combined hyperuricemia, right? Combined factors. So heavy alcohol intake. Next one, it is the dehydration. These factors actually triggers the gout. Next, it is the joint trauma in the joint. Next, it is the medical illness, surgery, intake of the high purine diet, urate lower therapy. So in such condition, the chances of developing gout, it increases or it triggers, it worsens the condition. Now, clinical features of the gout. So what are the clinical features? First of all, you see, due to the low solubility of uric acid, we know that the solubility of uric acid is less, right? The clinical features will come out. The more it is the features of the gout, it is more in the males as well as in the women who are at the age of post-menopause. So typically, or you can say typical gouty arthritis, it affects first metatarsophalangeal joint, that is the classic site. So the pain of the gout, it will start at the metatarsophalangeal joint, right? So in gout, the serum urate exceeds the solubility limit. I repeat, in the gout, the serum urate exceed the solubility limit. We have already discussed about the limit and threshold, leading to the formation of a MSU crystal, that is a monosodium urate crystal, and these actually get deposited in the joints, right? Now these deposits, they are known as the tophi. And now see, this inflammation of the joint, this leads to the inflammation of the joint, and this tophi actually causes the painful acute gouty arthritis, chronic gouty arthritis. These are the two conditions, right? So what are the treatment of the gout? So basically this is a lifelong disease. It will stay with the person, but the modification in the lifestyle, physical activity, it can somehow control this condition. Moreover, the drugs, it will just alleviate the symptoms of the gout. So treatment of the gout, generally we prefer low intake of the purine diet, like the person, they are not allowed to take the red meat or acidic fruits, right? Vegetables and lentils, these are completely kept absent in the diet of the person. Moreover, the person, they are restricted to take alcohols because it will worsen the condition, and consume plenty of water to enhance the function of the kidney. Now drugs, what are the drugs it is used in the condition to treat the gouts? So basically it's anti-inflammatory drugs they are taken. Colchicine, it is used for gouty arthritis. Moreover, NSAID, that is a non-steroidal anti-inflammatory drugs like indomethacin, ibuprofen, they can be used. Moreover, corticosteroids, they are also used. Dexamethasone, like drugs, these are also used in the acute conditions. So moreover, you can use the uricosuric drugs like probenicides. So this is all from the gout. So if you like the video, just press the like icon. You can share this video with your classmates and colleagues. Moreover, for further notification from this channel, you can subscribe by pressing the bell icon. Thank you everyone. Although it's a long presentation, but I hope I have covered the important topics, or you can say important concept from this presentation, which includes the catabolism of the nucleotide, moreover the hyperuricemia and the gout. So thank you everyone.